Hey, chicas. Welcome to Red Lips Real Talk Podcast. I'm Jasmine.
I'm Jessica.
I'm Monica.
I'm Mariza.
And I'm Deibys with a Y. Get ready. Somos Latinas from South Florida.
Bringing you real talk
on life, love, and everything in between.
Time to get real. Dale.
Hello, listeners. Welcome to Red Lips. Hello, everyone.
Hi.
Hello.
Good
Welcome.
evening.
Thank you for joining us in our next episode. Before I introduce our amazing guest that we have here today, we're going to dive deep in a really important topic that is affecting all of us, especially everybody here on the table. We're going to discuss menopause and midlife and what Gen X women need to know. Mm-hmm. Did you know that more than 65 million Americans are part of Generation X? Us scrappy, independent, latchkey kids who grew up fending for ourselves in the 80s. Now, as more than half of them are women, we are navigating a new chapter, perimenopause and menopause. We're in this boat together, ladies.
Oh, yeah.
Oh, yeah.
Yes, we are.
And sometimes it's sinking.
Yes, feels like that sometimes, definitely. Unlike previous generations, Gen X women aren't just accepting the changes in their bodies without question. They're searching for answers. We are demanding better healthcare, and we are refusing to suffer in silence. So we're turning into bloggers, social media, podcasters such as Red Lips, because let's be real, we weren't given much of a roadmap from our mothers or even our healthcare system. That's where today's guest comes in, Dr. Maureen Whelihan, a board-certified gynecologist and menopause specialist, and she's amazing, is seeing this shift firsthand in her Florida clinic, where she says Gen X women are showing up before menopause even begins, looking for solutions. She's here to break it all down, what's happening in our bodies, what we can do about it, and why we don't have to suffer in silence. So grab your coffee, your wine, whatever gets you through the day, because we're diving into menopause the Gen X way. Thank you for coming, Dr. Whelihan.
Welcome.
We are so excited.
Yes, thank you for coming.
Awesome.
So before we get into the nitty-gritty, tell us a little bit about yourself.
Well, so I started off like most OBGYNs, delivering babies, having all the fun. But at some point, I decided I wasn't going to do that anymore. And when that stopped, when the OB stopped, my practice changed. All of a sudden, the women that were coming in to see me were 40 and over and had a whole new set of complaints. Low libido, hot flashes, irritability, PMS. And so while I was interested in these topics, I felt like I really needed to know more. And so I joined an organization that really focused on women's sexual health, the International Society for the Study of Women's Sexual Health. Who knew that there were all of these people specializing in this? And with that, not only did I have the interest in helping the women, but I then learned what was available and what was going on to create these problems. And so with that, I, of course, learned about all the hormonal adjustments and things that happened in regards to libido and sexual health, but just across the decades, how women have to evolve with their health and what the benefits of the hormones are and how we can just feel better. And someone has to listen. If there's anything I've learned throughout this time is that women want to be heard. And the most common thing I hear is they feel very dismissed by their physician. It's all in your head. Hey, welcome to the club. We're all like this. Absolutely not. And so with that, I've noticed that about a third of the women coming into the practice now are in their 40s. They want to hit the ground running before they even lose that last functioning ovary. And so get ready, ladies, because we're going to share some facts and make everybody feel better.
Oh, I'm excited.
wait.
I know. I can't wait.
I cannot wait.
We need answers. Well, going back, since with the introduction, I quoted certain specifics in the article that I happened to come across, which I thought was an amazing article that you're mentioned in, along with another doctor, Dr. Claire Haver. And I remember the first time, for the audience so they know, Dr. Whelihan is my doctor. And you changed my life. You really have. You've really changed my life. You saved my marriage.
Thank goodness.
Thank you for saving me. And so the article I felt like really represented my journey. It stated that I found information through social media. I mean, I was really quick a year and a half ago at my wit's end. I thought I was going crazy. Really, and that particular phrase is a lot of what my friend's description utilizes. Like they feel like they're going crazy. And I had really weird symptoms at the time. I had like frozen shoulder. I had itchy skin. I had itchy ears. I had rheumatoid arthritis in my hands, which I self-diagnosed for like years, not unknowing that it was part of also perimenopause. I had joint pain in my hip. So I suffered with a lot of pain, and I wouldn't say anything to anyone because I thought, oh, this is how it is being in your 40s. This is just part of being 40s. Then I started losing my hair. Then I was bloating. I had, my gums were bleeding. I had the weirdest symptoms. And then we went into a whole other level. It was cognitive changes. I was having panic attacks, anxiety. I had issues with word finding. I would walk into a room and not know why I was in there. I had irritability, mood swings, and it just felt like I was going downhill. And I remember I was at my wit's end, and I was not able to make simple decisions like, Jessica, what do you want for your cabinets? What colors do you want to choose? And before I used to be like, hey, on my toes, like I was able to like, yeah, look, I could figure this out. And I found myself I thought I was getting the beginnings of Alzheimer's. And then I was just like, I need answers. This cannot be that this is where I'm at in my life. I have toddlers. And so when I went to, I started looking for answers on social media because I was like, I cannot be alone. Then I came across Dr. Claire Haver, and I went into her website, and I found a clip where she was mentioning how you can find a provider near you that specialized in menopause. And it was in the Menopause Society. I found you, and I was like, holy hell, I got to make an appointment. And I came into your office, and we started talking, and you listened to me. Mm-hmm. And I felt for the first time so relieved, not alone, and comforted, to be honest, and relieved that I wasn't going crazy. And so with that said, I think it's important to really start at the basics. Like, what is perimenopause, and what's the difference, and what are the hormone changes that we're going through?
Mm-hmm. So the ovaries start functioning when we start our periods, and they stop functioning for most people around age 51, but it's genetic. So some people will go through at 48, but there's a period of time in the 5 to 8 years before the last period where all hell's breaking loose. Let's face it. Your hormones are up one day, down the next day. 1 month you feel like you can run 10 miles. The next month you feel like you're dragging cinder blocks behind your butt. Yeah. And so, and I remember all of this myself, having gone through that. But what's happening is that the ovaries are not as predictable and reliable. So that perfect 28-day cycle is no longer. Sometimes it's 25 days. Sometimes it's 30 days. And so with this, your hormone levels are fluctuating. They already do anyway. So we already feel neurotic most of our lives because we have 2 weeks of feeling fabulous with estrogen and then 2 weeks of being bloated and bitchy with progesterone. And so we're already on this seesaw. Now you're going to shake it up a little bit and make some levels of hormones that are just not stable. And so that's where all the aggravation begins. For some women, it's clarity of thinking, focus, how many times a day I hear foggy brain, difficulty in my ability to focus. Sometimes it's hot sweats and night sweats, and my ears are uncomfortable. My feet are hot. Everybody's description of what it does to them is a little different. And so understanding that it shows up in each individual in a different way. For some people, it's weight challenges because they're eating like a lunatic because they feel up, they feel down, they're hungry, they're not hungry, and they're packing on pounds, and they're really just another level of aggravation because then women start focusing on that. So these hormone changes are up and down. So the goal when we're trying to manage this is, I just want to keep you off the lows. Your highs are still pretty high, and you're not complaining to me when you're there. Your lows are where you're acting differently. Who do we take it out on? Our family, of course. No wonder divorces happen in people in their 40s. For goodness sake, the wife becomes who is the woman in our house? The kids say, I want the nice mommy back.
I feel like every other month, it's a different person that gets him more than the other. Sometimes the dog's aggravating me more than my husband. Sometimes
you're like, whose turn is it?
And so all of these changes are happening, and we really do take it out on our family, but we then take it out on ourselves because there's so much guilt involved in our bad behavior. And especially when it's the PMS or the irritable, crazy behavior. So now it's self-reflection on how we've behaved today, and we're embarrassed at what we did in the boardroom at work or so forth. So I'm so celebratory when the husbands manage to stay along. I try and focus on sexual health sort of early. So like throw him the bait. At least if we can keep him in
get him hooked
with
in.
the sex, he'll tolerate any bad behavior.
Yes.
There is a limit for that, but for the most part. So our poor family, the good news is if your marriage makes it through this difficult time, it's usually very strong. Nice. So that's a good sign. But managing and navigating these waters and trying to pick off, I always start the conversation with, what's the most bothersome symptom for you?
Right.
And, sometimes I hear something like nausea. I'm like, okay, that's not directly menopausal, but let's see what you're really trying to tell me. And then we get into another story, and I'm like, okay, I can see the nausea link here. So listening is really part.
How can someone determine if they have perimenopause?
Everyone goes into the perimenopausal period, which is the 5 to 8 years before menopause. Now, you don't know when your periods are going to stop unless you have an older sister. Your older sister if you share the same parents, then it should be about the same, assuming that neither of you smoke. Smokers go through younger than non-smokers. But sisters generally all go through the same. So when I see somebody at 51 and she's still having a period every month and hasn't skipped, well, you're not going to be the national average, which is 51. How old was your sister? Oh, she stopped at 54. Well, there you go. It's going to be 54. Don't rely on your mother. They seem to not remember that perimenopause was a thing.
Yep.
It was a non-issue. I don't know. I remember my mother. There was something going on. I didn't know what it was called, but it wasn't good.
Yeah.
So everybody goes through perimenopause.
So what is hormone replacement therapy, and how does that work?
And I don't know that replacement is what we use anymore, but hormone therapy.
Okay.
So hormone therapy is simply saying, how can we manipulate the regular hormones? So for girls, estrogen is our main hormone. Testosterone is another hormone we have, and progesterone. And so how do we manipulate those to make you feel the best? So you have to know what they can do. What is the end game for each of these hormones? What can I actually improve? And then we use those.
And so do you have to do a blood test? Because I found it at least for me particularly, I came into your office and I knew what I needed. I was like, you're putting me on. I was like, please put me on HRT.
Yeah.
But how do you know if that's a good fit for you? How does that work?
So levels are really not helpful for a couple of reasons. One, they're changing constantly. In a given cycle, they change twice in a day. Our hormones are a little different in the morning, higher in the morning between 4 and 8 a.m., a little lower in the afternoon. Throughout the month, estrogen predominates from the first day of your period till ovulation, and then progesterone tends to be the one in charge. Testosterone is relatively stable throughout the cycle. And so measuring a level isn't helpful to me because you're not a number. You may need more estrogen and you may need more testosterone. So when people want a number, I'm always like, well, what number are you shooting for? Because I'm really shooting for a good end result. And in my mind, I know what products I'm using and how much I'm delivering to you. So I have a sense on what level I'm giving you. But if you're not feeling good at the level I think you should be feeling good, I'm going to give you a little more. When I start to move into ranges that seem not normal, then I'm going to do a level to make sure you're absorbing what I'm giving you. So that's when levels become apparent and helpful. When people are compounding products, that means an individual is making a special potion. It's usually done in a cream. Creams aren't absorbed through your skin as well. Your skin is a barrier. It's intentionally made to protect you. So things will go through better if they're alcohol-based as opposed to just a cream. So sometimes levels are used to get the patient back to the office. You'll notice in a lot of these boutique clinics, come on in, let's check your levels. 3 months later, come on, we'll check your levels again. They know you're coming in to find, am I the right number? And are you going to feel happier because the number she said was good, or you were on that way still feeling bad when you're on your way to that clinic visit? Right. So just because your number is great, are you better? No. So we want to know how you feel. And if you use FDA-approved products, you know how much you're delivering. So you're within a safe number.
So speaking of FDA, what are your thoughts on testosterone?
So there are no FDA-approved products for testosterone, but there are several trials, long-term 5-year safety and efficacy trials saying that it is both effective for women, especially for libido. That's what it's been studied for. And it's also safe. No increased breast cancer risk, no increased cardiovascular risk, all the things that you might be concerned about. So these have been played out in 2 really nice long studies, both 5 years. Susan Deibys was the lead author in these. And so we have data, but when the companies tried to bring something to the FDA for approval, the FDA just wasn't open to testosterone in women. So for the last 20 years, we've been prescribing it off-label. So I use an FDA-approved product for men because we know that women need about 10% to 20% of a man's dose. So that is our goal when we're looking on where do we want to treat women. So we use 10 to 20% of a man's product. So if you know what the men use and the dose you're giving to a man, which is well studied, then we know where to start for women, and then we sort of take it from there.
Well, I can speak about that firsthand because I got testosterone.
Yay.
It was the darkest time of my life. I feel like I'm listening to everything that you're saying, and I feel vindicated. I feel like, wow, like I'm actually listening to someone who's making me feel like all the things I was going through when I would go to my gynecologist. I was with him for 10 years. I stay, I'm loyal, you know, but all the time it was like, well, that's the way it is. You know, it's a part of aging. And I accepted that answer. And I confided in a friend and she was like, oh, no. And I really appreciate so much that conversation. I feel like it was meant to be. And I ended up getting testosterone. My level was non-existent. It was about 7, I believe. It was so bad, Dr. Whelihan, that when you mentioned, you know, difficult times in your marriage, and then if you're able to get over that, how you're going to be in a good place, that's exactly where I am now. I feel like I'm in the best place in my marriage, but at that time, I was a completely different woman. And if it wasn't because he was the one that was putting in the weight to say, no, I'm fighting for us, I probably would have left. I was in a dark place. I don't even know who that woman was. So by the time I went to see a licensed practitioner nurse, they put a pellet. A pellet. And she said, it's going to take a little while, maybe a couple days. And I'm going to tell you, within a matter of 7 days, I just was like, let's go for a walk. Let's go out. I was happy. I wanted to make love. You know, I just felt so pretty. You know, I felt wonderful. Were there side effects? Yeah. I got a little hairy. Nothing a little waxing can't fix. You know?
Exactly.
I gained about 4 pounds, but I didn't care. I didn't care because I just felt so wonderful. And that's why I've become personally a little bit of an advocate with my friends and family who are going through this. And sometimes there's a little bit of shame talking about this, especially in the Latino culture, because we didn't grow up talking about this.
Right.
And then now, like you, Jesse, said about the Gen X community, how we are not taking no for an answer. And I love what's happening, that we're able to find solutions to making ourselves feel better.
And don't take no for an answer. So pellet therapy sort of was introduced. It's a compounded, waxy bullet, if you will, that's implanted under the skin. So the intent is that it can last longer. With that, in order to get something that lasts 3 to 6 months, you have to raise that level pretty high because you've got to counteract it. It's going to come down over time. So we consider pellet therapy as high dose therapy. So
it was a high dose.
Yeah.
Because I had my numbers checked.
The numbers can go up to 800 sometimes.
Well, no. God forbid. It'd be like Hercules. No, it was up to 100. I got up
that's
to 100.
not bad. Yeah. Actually, that's the numbers we're shooting for.
Yeah.
So that is not high dose therapy.
Oh, okay.
So when you look at the studies from Susan Deibys on libido, the target range is 50 to 150 on the testosterone levels. So that's nanograms per deciliter. You guys don't need to know that. With pellet therapy, we usually see numbers 200 to 800. You figure that's about a man's level. Now, an 80-year-old man is 200. Some of our husbands might be 200 as well, if they're low T. But if you get above 250, sometimes women will feel a little bit pressured or irritable. So some women may experience it as too much. Certainly acne, hair growth. But you're right. If you're feeling strong and vigorous and a little more interested in sex, yeah, you get a lot of wicked, sexy thoughts in your brain. And that's really fun because you're like thinking what you're thinking and going, oh my gosh, I hope nobody knows what I'm thinking right now.
Well, I like how you posed it. I remember when we talked about, because I do the gel testosterone, which has been great. And I remember, I like the way you posed it. I don't know if you remember, you probably use it on your pages, and you told me, you were like, well, do you want to go hunting? Or do you I forgot what else you said. You said, do you want to go hunt? And I was like, that's a great way to put it.
Right.
Because I was like, I think I'm good where I am.
You can certainly have multiple layers of being vigorous. So gel therapy gives you the ability to go as slow and low as you want. A pellet is put in you, so you got it.
May I ask you a question about the pellet?
Yeah.
Because I've only had it put once. So I feel like now I'm ready to
You're ready for the next one. It's been 3 months.
I actually can feel, well, no, it's been longer than 3 months. I think it's, considerably longer. It's been about 6 months. Yeah.
Awesome.
So now I'm starting to feel like, I'm starting to feel sluggish again.
Right.
But I do have to be honest. It was very sensitive and sore in the buttocks area where they implanted it. And then about maybe 4 weeks ago, it started to like sting a little bit, just like a little sting. It wasn't a huge pain, but I was wondering, is that it like completely wearing off and you can feel it, or am I crazy?
You're probably just feeling where the pellet was put under your skin. So that would be a local skin reaction.
Oh, okay.
Unrelated to your skin is not really telling you that it's dissolving. The way you feel is that sluggish feeling.
Yeah, it's back.
The slump.
Yeah.
A lot of people will say. So, your body
do you
is telling
recommend
you
because it worked so well for you that I should continue with the pellet, or maybe try another alternative?
I think you have success. So I would do what you're doing, especially if you're getting 6 months out of it. That's a value because when you
your
look at the
numbers
price,
aren't that high.
Yeah.
No. Well, I went to check them 2 months after they had put it.
So is that the last time you checked it?
Yeah, but I've been feeling great up until about 2-3 weeks ago.
Time for another pellet.
I'm just starting to feel like,
Get that pellet in.
It's calling you.
know, it's funny. My husband was like, "Is it time to get the pellet?"
They know before we know.
Yeah, he's like, "You're getting a little cranky."
She's not chasing me around the house.
She's not hunting.
That's right. She's not standing in front of me naked.
Oh gosh, how do you know?
So I wanted to go back to Jasmine had mentioned, being in a dark place with perimenopause, and I want to add this. This is to me was crazy. It says suicide rates among women aged 45 to 54 have risen by 60% over the past decade because of being in this journey. And that's scary because I know I was in that dark place. Many women, and it's scary too because even I notice friends of mine that are going through their own journey, and I can foresee like that isolation and that reclusiveness happen. Like to me, that's what happened to me because I felt like I was malfunctioning. And it was, as you had mentioned, Dr. Willie, like you took the words right out of my mouth. That's exactly what I was feeling, was like, there's a shame behind it. And it's like, you don't want people to see you like that because you're trying to figure out what the hell is wrong with me. And I can't function in society. So with mental health, how does perimenopause impact mental health?
That's a great question. That's a pretty alarming statistic, unfortunately. But it's very interesting. Even women who have never really had a problem with anxiety before will come in. Now, they'll say, I'm having these big thumps in my heart that go up into my neck. So, of course, that induces panic because you're sure you're having a heart attack or something because you feel like crap.
What it feels like.
Yeah.
Right.
Yeah.
But new onset anxiety is really common, and these palpitations. And a lot of times when women, are telling me about this, sometimes it's hard to tease out. Is this a mood disorder that's not been treated and this is not new? Or, especially if I'm meeting somebody for the first time. So I always go back and say, well, how did you do after the birth of your child? And some will say, I needed Zoloft for, the first year or for 6 months. So postpartum, these swings in the hormones are very similar to postpartum. You had the big crash of hormones from the placenta comes out and the estrogen and the progesterone crash. You're sleep deprived. You've got a newborn. It's a mess. Your hair is being lost. Your 50% of your hair volume is gone. It's very similar. And so if they had a mood disorder during the OB period after the baby, then it might need something more than just hormones at menopause. But for the girls who's never really experienced significant anxiety, estrogen may do the trick. And I think that a lot of OBGYNs, other than those who know about hormones, the ones who are dismissive aren't looking beyond the hot flash. We all know it helps with hot flashes, but that's not always the primary symptom that's affecting my patient. And so thinking beyond the other good things that it does, the joint pain and the foggy brain and the concentration and the sleep, you start to really understand you've got to listen to the patient, and you're not going to hurt anybody by giving them a little bit of estrogen. I'm giving you about a fifth of a birth control pill is the amount we're giving you when we start you on hormone therapy. That little bit. And everybody knows that birth control pills are fine. So I think not being dismissive and saying, there's nothing to lose here. Let's try it. We might have to try something else, but let's try it.
Absolutely.
Especially for the mood part.
Yeah.
Because nobody can live in anxiety. Bad time.
Yeah, it's scary.
Dr. Whelihan, I had a question. I noticed in the beginning of the episode, you had mentioned that you saw some changes in your mom and that you remembered that. Do you think that that's something that led you into wanting to go into this career?
As early as fifth grade, when you wrote, what are you going to be when you grow up? I was going to be a pediatrician that delivered babies.
Oh, wow. So you knew.
So pediatricians don't deliver babies. So I had that a little bit confused, but I was going to be a doctor early on. Then I was a labor and delivery nurse coming out of high school. I said I was a little too rowdy to go to medical school. I wasn't really being good at that time. So I went to nursing schools, and I was a labor and delivery nurse, thus the love of babies. And I wasn't sure I was going to like gynecology. I loved obstetrics. Well, fast forward, gynecology is really where it's at because it's the women in their most desperate times of their life throughout their decades from, I'm in practice now 30 years. So I've been taking care of women since they were young girls. I always say, you used to come in here when you were a fetus and now you're a grown woman with children.
Wow.
And we joke about that. So no, I don't think that my mom's moodiness was a sign to me at that time. But looking back, you're like, exactly the right time of her life. And a very difficult time for her, but I wasn't thinking about her.
Do you feel like it makes a difference if your gynecologist is a man?
No, because there's some really good hormone docs. Now, I will tell you, it makes it easier if you experience something as a doctor. So if you're a doctor and you have cancer, you're going to be better at, being empathetic about cancer than the doctor who hasn't had cancer. Plus, you can share your story. So being a female physician who's had perimenopause and is in menopause, you've navigated the path and you sort of know, tried this worked, this didn't work, let's try this for you. So I'm always a little fascinated by female physicians that are in the menopause whose patients come to me and they say that their doctor said, we'll all get through it. And I'm like, you gotta be kidding. Like, how can someone suffer through that? But it's a different approach.
Yeah, that happened to me, actually. I went to a woman doctor and I was expressing things that I was feeling. This was a couple years back. And she was just looking at me like I was complaining. And she just was like waiting for the appointment to be over, kind of looking at me like, so this is why you came in today? Like, I just felt so like dismissed. And I was in shock because I was like, I went to a woman thinking a woman would understand me better. Right. I ended up going back to my original gynecologist as a man. He delivered both of my babies and he was great for that. But like you said, now we get to a certain age where it's like you have a lot of women that come in at their 40s and all their needs are different than when they were coming just for regular checkups and pregnancies and stuff like that.
Everybody can't be an expert at everything. You have to pick your passion. But what I wish is that someone would say, I don't really know anything about that, but I'm going to send you to so-and-so.
Right.
Because this is their favorite topic. Sexual health obviously comes to me a lot because that's the last thing that an OBGYN wants to talk about. It's a long discussion sometimes. And, they'll just say, go talk to Whelihan about that. I don't even want to begin the conversation. But at least they've done their duty to say, I hear you. You have a complaint I don't know anything about. People ask me stuff that I don't know about. I usually am then looking it up because I want to know something about it because I just want to speak to it. And then I say, I know who's good at that. And I make a referral. So I think that's our duty as an educator is to say, I'm at a loss here for you. A lot of the rheumatologic stuff, autoimmune disease, very complex. So, I'll say this number is abnormal and it seems like it needs some more evaluation, but this is not my expertise. So let me get you to the rheumatologist or whatever.
Right. Yeah.
I agree with that because I think a lot of, if there's someone listening to us right now and they're like, wow, I go to my gynecologist and they're telling me, well, that's the way it is. You need to be your own advocate. Oh, absolutely. And you need to find answers to what you're feeling.
And women do that much more today than ever before, right? You used to be just the dutiful wife. I remember somebody gave me a booklet when I got married, and it was what the woman did in the 1950s. Meet your husband at the door, make sure you have a nicely pressed dress on, make sure the children are clean but quiet. And, I giggled through the book going, can you imagine that women did just this? No. Now, today, women are the businesswoman. I come in the door, here, take my briefcase. My husband does the grocery shopping.
It's like that movie, Mona Lisa Smile.
Yeah.
So they tap into that.
Today's women are not settling.
Absolutely.
Well, let's talk about today's women in the workplace. No. Because I feel like I hear a lot, too, that women tend to, like all these symptoms that we were talking about, fatigue, concentration, it seems like it affects a lot of women in the workplace. And we have like some statistics that show that 54% of employees report fatigue as a major workplace challenge. 47% struggle with sleep difficulties impacting productivity. 65% say perimenopause negatively affects their work performance, with 18% taking sick leave due to symptoms.
Without a doubt.
Yeah, so you get a lot of women coming in.
Listen,
voicing this.
Especially women that are working, and especially women in power positions are like, I had a meltdown in the boardroom the other day.
I'm laughing because we can all relate in one way or another.
I so appreciate you sharing that.
And they say, if this continues, the rest of my board, which is mostly men, are going to kick me out. And they, of course, recognize their bad behavior. Usually it's just a PMDD attack, PMS. And they're just saying, you got to help tummy, or I'm wearing a suit. I cannot be pouring down sweat when I'm in the middle of a conference with a bunch of men, especially. So bad behavior and women in business, but sleep is number one. If I go after anything, women come in with what they want to go after. But when I think of what one thing can I focus on that will fix 6 things, it's sleep. And it's sleep maintenance. They're deadly tired. They're going to fall asleep in a second. Our watch will tell us our sleep latency is 3 minutes, but then they wake up and then their brain starts turning on. Sleep rules everything.
Yeah.
So if you're having trouble sleeping and you're going through this change, what's something that someone can do to help them sleep?
There's lots of ideas. So some people want medication, some people don't want medication, some people want over-the-counter stuff like melatonin, Tylenol PM is safe during pregnancy. But progesterone has natural progesterone derived from the wild yam, readily available at Walgreens on your insurance for probably $15 for a month. Has a relaxing property. It helps you stay asleep. It's amazing. Some people just say, I cannot believe that something as simple as this has changed my life. It can help with a little bit with hot flashes, but mostly it just gives you a restful sleep. It's amazing. And then there's other sleep meds. I mean, some people have a lot of sleep dysfunction. So we really like to hone in on that. It controls appetite, it controls libido, right? Sleep comes before food, comes before sex. So you better get to sleep and you can get something to eat. But, sex comes last on the list. So I've got to fix sleep.
And what seems to be like the magic number of hours that we should really be getting?
Probably 8. For me, it's 9. My number is 9.
Mine is 8.
I need three sleep cycles, and my sleep cycles are 3 hours each. So 9 hours. And so the answer is when you wake up spontaneously.
I do.
Without an alarm clock.
I do.
That is good sleep.
Yeah. I love my progesterone.
And sleep also, because I've noticed being sleep deprived also can raise the level of anxiety.
Oh, yeah.
So if you are having anxiety and you're not getting restful sleep, it's going to add to the anxiety. Sometimes you may even just get anxiety because you're not sleeping well. It might be the only reason.
Absolutely. It makes you anxious. It makes you hungry. It makes you irritable. And then you're trying to get through your next day. Mm-hmm. And just desperate to get sleep again.
And now you're more, fog brain. Yeah. You can't concentrate. Yeah, it adds to it. Yeah, that's a very good point. I would feel like that. Like I have always said, if I don't sleep well, I don't function well the next day.
Right.
Just forever. I've always been like that. I'm someone that's like, if I don't sleep well, I just don't know what it is. The next day, I'm not like getting my job done correctly. I can't remember everything I'm supposed to do throughout the day.
When I was married in my first marriage, my husband couldn't stand the beeper going off. We had beepers back then every time I was on call, and
we had beepers too.
Yeah. So it would be like 17 calls a night. When you were on call, I might have run out 3 times to do a birth. So he would always sleep in the other guest room. Well, he got comfortable staying over there to sleep, and I got comfortable him staying over there to sleep, and then I had a good night's sleep. And we learned that sleeping separately gave both of us a really good night's sleep. I didn't hear his snoring, and he didn't hear my beeper.
Right.
Fast forward to my second marriage, and my second husband is not a snorer, which is great, but he's a snuggler, and he likes to, grab a little of this and likes to just cuddle up. But I was so used to sleeping alone for 27 years of marriage that I was like, wow. Some nights when I really need that sleep, I'll say, I'm going to put up a little pillow barrier here tonight. And this is not to keep you away. When I hit my 9 hours, I'm going to remove the barrier. And he gets a kick out of it. But I'm like, I need my sleep. I recognize what makes me function and what makes me smile the next day. So
is there any other supplements that maybe you would recommend or that work well for just all types of mood swings?
Sure. So progesterone actually helps with the PMS too. Magnesium, some people use magnesium, plus or minus on the data there. It helps you poop. So, being constipated is also not a good thing.
Which magnesium do you recommend for that?
Whatever you can get. So there's glycinate. Somebody told me there's a new one like taurate or something. Think about just getting any magnesium, about 500 milligrams. If after a week of that, you're not pooping good, then you go up to 1,000. because constipation, that doesn't feel good. You're bloated. You just are uncomfortable. So, but magnesium also helps you sleep. Kava, there's a lot of over-the-counter. Most of that stuff is not tested. So melatonin, 10 milligrams seems to be effective. CBD, plain CBD, whether it's full spectrum or broad spectrum, does not have the psychogenic properties. So you don't have to worry about getting a buzz unless you want one.
Oh, that's not too bad.
That would be the full spectrum, by the way, if you were trying to get that 0.3% chance that there's some THC in there. Although the Delta 8 evidently is much more psychoactive for sleep. Meditation, mindfulness. Some people have white noise in the background. So don't exercise too close to bed. Of course, do not drink caffeine after 12 o'clock noon. Look at medications. Some medications are stimulating, so you have to be careful. And then we go with progesterone as our sort of first natural approach in the medication world. And then we add things like trazodone or mirtazapine sometimes. I like hydroxyzine. We use a lot during pregnancy. It's actually an antihistamine, but it has an anxiolytic property. It means it sort of cuts anxiety, yet it's an antihistamine. So safe and effective, great for sleep for any age.
It's great. That's great. I love that.
A lot of options.
Yeah.
Yes.
And one last thing for the supplements is there because I've heard like vitamins, sorry, I can't get the word out, like B6, I think it is. That can tend to be good for mood swings. Obviously vitamin D.
B complex in general is your sort of stress vitamin, and it's a water soluble, so that means you can't take too much.
Okay.
I do one called B100. That means there's 100 milligrams of each of the Bs in it, and so you pee out the extra. When your urine is a nice neon yellow, that means you've absorbed plenty, and now you're excreting the excess.
You should take that daily.
So a good B complex daily. You should all be taking vitamin D, vitamin D3, at least 1,000 units a day, reduces our risk of breast, ovarian, and colon cancer. So cancer preventer, it's an antioxidant. A multi, if your diet doesn't always get what it's supposed to get, a multi is good to have in general. Those are probably the primary ones. Zinc is good for your skin and nails. Some people take zinc.
What are your thoughts about creatine?
Some people are having some elevated liver enzymes with creatine.
Really?
I don't know what the number is of what you can take. So, creatine is used a lot in protein powders and protein building. I think that women just need to be consistent with their program. Lift weights. So the older we get, the more important strength training becomes. You don't have to be chest pressing 30-pound dumbbells on each side. You can do a 10-pound or an 8-pound weight on each side. It's not supposed to be about getting big. It's about getting toned and keep maintaining your muscle mass, because that's what's going to burn the calories that allow us to eat more, which is always our goal.
I'm glad you said that, because I remember meeting a woman a few years ago, and she was about my age, and she didn't want to do weight training or lift weights because she was like, oh, I don't want to get big. And I was like, no. Like, I tried, but she just refused. She was like, no, I'm going to get bulky. And I'm like, no, that's not going to happen.
That would be, you'd have to lift heavy weights, short reps, heavy weights will bulk you up, and little weights with lots of reps will keep you lean and toned. And, testosterone, while we talked a little bit about testosterone earlier, and the data is all centered around libido, what women will tell you that take testosterone is, I happen to be one of those ladies that works out, 5 or 7 days a week, and I notice I get more definition in my muscles when I'm taking testosterone. So even though it hasn't been studied for muscle mass in women, they have had studies in like nursing homes looking at fracture risk reduction when they give a little bit of testosterone to the men and women, the little frail people in the nursing homes. So we know that it works around that area. So another reason to consider taking a little bit of testosterone to enhance your day.
A plus.
Yeah. I'm ready.
I'm in.
I want everything.
When can I start?
I know. Dr. Whelihan, what's your regimen like?
So
how do you get it in with your schedule?
Oh my God.
What do you do?
So I get up at 4:30 in the morning, because I have a husband that's knocking on the door at that area. And listen, nature is doing its thing, so it's a lot less work for me at that hour. A, and B, I can check that box off, so I don't have to worry for the rest of the day.
Happy home checked off.
Exactly. Who wants to come home after a podcast at 7:30 at night and have to get naked? I'm thinking about snuggling and watching a little something,
And then putting the barrier up.
and then putting my pillow barrier up for a little. I'll snuggle for a while, and
It's funny. I have the pillow barrier, and some nights when I get back from the podcast, he's like, "Get that." He's a snuggler too.
Oh,
so
yeah. So I do a lot of that. I do a lot of the
My husband loves to spoon.
Oh, I know. But
my husband snores.
But I'm the same. I like the snuggling. My husband likes the snuggling, but I can't sleep throughout the night like that.
Exactly.
We snuggle for like 5-10 minutes.
We're done.
Yeah. And then it's just like, there comes a point, whoever moves first respects the other. It's like, if I'm going to roll over now because I got to get in a comfortable position, like I'm going to sleep, even though it takes me like 30 to 40 minutes to fall asleep.
Yeah.
My husband's out in like 5 seconds.
That's it.
He'll tell me something like, "Oh, tomorrow I want chicken parm for dinner." I'm like, "How did he just fall asleep?"
That's awesome.
Yeah.
Yeah. So, I think that
It's in the genes.
And then, the reason I get up at 4:15 is after I take care of that, then we work out in the morning before we go to the office. So
That's great. Together?
yes.
That's beautiful.
So-
For how long?
Well, I usually can do 20 minutes. He's retired, so he can do a little bit longer.
All right.
Well, he did exercise before that. Too.
Yeah, we both did.
That counts.
Although I prefer to take a passive role at that hour. So my morning is very efficient.
Yes, it is.
I've got
start
more
the morning
stuff
right.
done. Right. And then I'm going to the office, and the first vagina is at 7:30. So my first patient is at 7:30, and then the day goes. So it just rolls from there. And of course, at lunchtime, I don't do a lunchtime per se, because then I certify patients for medical cannabis during that time, and then roll back into GYN.
I have to say something really quick. I noticed in your office, which is something that I really admired, you have a standing desk.
Oh, yeah.
You don't have a sit-down desk like this.
No.
And I thought I saw one day a walking pad.
I do. So, I stand a lot. It's really good for your back when you're standing all day. Plus, it keeps me on time, because if I sit down and start chit-chatting with the patient, I may knock it up. The walking pad is super cool, but I have motion sickness, so I learned that when I'm like at the keyboard and typing and walking on the walking pad, that sometimes I was getting nausea. So I was like, okay,
I would get nausea.
I can check my email on the walking pad. I can read things, but the typing, moving my fingers and looking at the keyboard, I would get nausea. So I moved the walking pad to my computer that basically I check mail, or sometimes when I do telehealth calls, I'll have that thing running slow. You just have to be careful because you don't want your head moving. Right. On the
Are you on the treadmill?
Yeah. Like, does she have a tremor? Does she have a new tremor? Or, what's going on there? But yeah, the walking pad's sort of cool.
I love that.
And, of course, I have to always shop things and find a great value of a good motor. And but they're inexpensive. It's like $300, and it's exercise, just a few more calories.
Right. That's right.
So that
getting
maybe I can
Getting
have that carrot cake.
That's right. Love that.
Yeah. So, but I think that, really focusing on your own health, understanding your sleep requirements, because if you get that sleep like you are a happy person when you wake up. You wake up with a smile, and starting your day with that, knowing that you have a whole day ahead of you, and then you take care of all your little check boxes on the way, then as the day goes on, you can sort of wind down and enjoy your evening. So, everybody has their way. Some people are really energetic in the evening. That's never been me.
Me neither.
I don't know how I used to do that when I was younger.
Me too. It's like, how did I stay up till like 3, 4 in the morning?
No. 9 o'clock, I'm in bed.
Okay, so I was going to ask.
Me too. I was counting. I was like, she has to go to bed like at 9.
At 9.
Okay.
Yeah. And sometimes it's 8:30. So that's the beauty of having no children.
I was just going to say that, because I actually recently just started trying. I only did it like maybe 4 days, waking up at 4:30 in the morning. And I noticed that my day was just more productive. Like when I got to work, I was actually like in a great mood because I have been awake for hours.
Right.
I'm not getting there like just being awake for a few, but it's tough because I do have 2 small children.
Oh, yeah.
Well, a teenager and a 10-year-old, but they're still young. They need my full attention. And I'm like, man, like, and sometimes I'm like, hurry up. I'm telling you guys, you got to get to bed. I can't go to bed until you go to bed. And then that's like my song and dance.
Yeah.
So it's hard. So then there's nights that I go to bed late and then I'm looking at my husband, I'm like, I can't wake up at 4:30 in the morning because I can't get just 5 hours of sleep, because I would normally get up at 6.
Yeah.
But it's just like 5:36 and it's just like I'm still rushing, getting the kids, trying to get to work. And then I get to work and I'm just like,
Exhausted.
yes.
Already.
So I had that time to myself in the morning and it was nice, So I'm trying to so I was counting, it was like 4:30, 9 o'clock.
9 o'clock.
to get
Even
8
on the
hours.
weekends,
Yeah.
big partiers we are. Even on the weekends, and a sleeping in would be 6 a.m. We get more done before noon than any of our neighbors. So
I think that's the secret, though. I think it's getting up early is how people get a lot of things done.
Oh, yeah. And he likes to go fishing. He likes to push off the dock at 7.
Oh, yeah.
So
Do that. You got to get up early.
Little earlier for wahoo. When you're looking for wahoo, you got to get out in the dark. So, sometimes it's like, okay, let's go catch some fish.
But it is proven. They say that people who are extremely successful are already up and at it at 5 a.m.
Yeah.
Yeah, I think there is something to the personality that is a morning person.
Yeah.
They have that 5 a.m. club.
Yeah.
I haven't read it yet, but it's
there you go.
very true. Yeah.
I wake up at 5 a.m.
Yeah.
And I just like to have my quiet time before it starts.
Right.
So, but I think being in as I went through my 40s, I'm 49 now, and I feel like my sleep, and that's to have little kids. Life is going to change in a few years. They have their sound machine and they sleep 12 hours. Mm-hmm. So mommy gets her sleep, but to me, it's sacred.
Yep.
And when I was going through that, last year when it was just chaos, I was getting up at 3 a.m. for no reason with the rumination. And it was like,
yeah, can't do that.
No.
You really, sleep is so important. It's the beginning of recovery from everything. Mm-hmm. So.
For sure.
I need to go to bed more early. I have a really bad habit of going to sleep very late.
What time do you usually go to bed?
11:30.
Oh my goodness.
Yeah, that would be me. That is me.
I'm not
just trying
tired.
to change it.
Yeah.
Oh, you're not tired.
Oh, that's
tired.
okay. Well, do you have to get up early?
No, but I'm usually up at 6:30.
Okay. Well, that's not too bad.
Yeah. 6:30.
7.
Yeah.
But when you say you go
I
to
do
bed at
wake up
11, do
tired.
you fall asleep at 11?
I do wake up tired.
Okay.
Yeah.
No, I'm saying 11 o'clock, like you're in bed by 11, or you're like asleep
No,
by
I'm
11.
in bed by 11.
Right. So you're not really going to bed at 11.
No, yeah, 11:30. I go.
It depends how fast you fall
Oh,
asleep.
yeah. I was just going to say,
Yeah.
and then finally getting that REM.
I don't know. Just not tired at that time.
Yeah.
Yeah.
That can be tough.
What about for women with breast cancer? History of breast cancer or family history of breast cancer?
Well, I'm glad you brought up the history of breast cancer. So let's start there.
Yes.
There is a word out there that some women believe that just because their mother or sister or grandmother or 3 aunts had breast cancer, that they cannot take hormones. Mm-hmm. Fact, estrogen does not cause breast cancer. It is the fuel for an existing breast cancer. So if you have breast cancer in your body, it will allow it to grow because the majority of good breast cancers are estrogen and progesterone receptor positive. Your breast developed under the influence of estrogen and progesterone. So no surprise that a cancer in that area tends to have those receptors. Mm-hmm. So it's the better kind of breast cancer to have if you're going to pick one, because we know all the therapies are aimed at blocking estrogen and progesterone. But just because someone in your family has that does not mean you can't take birth control or you can't take hormone therapy, because remember, you're far more likely to die from cardiovascular disease than you are from breast cancer.
Yes, that's a great point.
Chance that you're going to die of a heart attack or stroke.
Yes.
So your life should be focused on preventing heart attack or stroke. Know your numbers, keep your lipids down, exercise, cardio, strengthen your heart, all that stuff. So when you're thinking about breast cancer, yes, I want you to know what your genetics are. So if you have a mother and her mother had both had breast cancer at 40, then I'm going to send you for genetic testing to make sure you don't have a mutation. 95% of women do not carry the mutation. Most cancers are not because of a genetic mutation. They're spontaneous mutations. It's just a change in the DNA, and it created this cancer. So 95% of all cancers have nothing to do with the genetics. But when those genetics exist, BRCA1 and BRCA2, everybody's familiar with, there's many others. Check CAGK, PALB2, there's a whole bunch of them, ATM. When those markers exist, then we're going to be imaging you more frequently, MRIs and mammo, rotating those. But it still doesn't mean you can't have hormones. Now, there's some great articles. I did a talk to one of the cancer survivorship groups, and I thought, oh man, I'm going to stir the pot with these oncologists. But I presented 2 articles that were 10 years of following women with breast cancer and women without breast cancer given testosterone therapy. Well, guess what? Testosterone is an anti-estrogen. So it does not stimulate the breast to grow. In fact, it would work against breast cancer. So when they looked at the studies, especially in women who took the Arimidex, the anastrozole, which is the blocker you have to take after the cancer, the women in the study had less than expected recurrence of cancer, or less than expected cancers overall if they were non-cancer patients. So when I have someone who's really worried about cancer, or a patient who has breast cancer, even though they're coming to me to be living on the edge and want to take hormones, I say, let's hold the estrogen. You have an estrogen-dependent tumor. Let's not give you estrogen because you have a cancer that feeds on estrogen. Let's start on testosterone and go there. Most of the time, as we've heard tonight, testosterone in itself is a miracle worker for some women.
I didn't even know that women had testosterone.
That's it.
I'm being honest. I was shocked.
I always say when women take adequate amounts of testosterone, they understand why their men behave the way they do.
Yes. I heard.
Yes. So for breast cancer survivors, we go in the direction of testosterone first. Obviously, I ask for permission from their oncologist, and it's part of overall wellness. I want them to be exercising. I want them to be eating right. I'm going to do my part. You do your part, and we're going to continue you healthy with your history of cancer. For women without personal cancer that is an estrogen-dependent cancer, there's no reason why they can't take estrogen unless, of course, there's some blood clotting factors like factor V Leiden, and people that have had a stroke, people who those are probably the biggest ones that we see, these markers for blood clotting. We tread lightly there. It's a conversation and some shared risk when we talk about it. It's not a hard no for me. I need you to understand what you're accepting and what's our benefit and risk ratio.
And so with those people, what's the approach that they have to take?
So for the people with having a history of stroke or heart attack, and some of them can be young, 48, I get them to quit smoking because that's often a risk factor. And I usually do very low dose. Again, if I can make them feel good on testosterone alone, but you have to be careful. Testosterone can carry some of those risks. And again, it's about overall health. So I make them pull the line on not smoking and exercising and keeping their sugars down low if they're diabetics. But transdermal estrogen, taking your estrogen through your skin, seems to be much less risky than taking it orally. So it is not common anymore that I would be starting somebody on an oral estrogen in the menopause. If you're 93 and you come to me and you've been on oral estrogen or Premarin for the last 40 years, I'm not going to make you change your product. But if you're a new start, I'm giving you transdermal or through the skin. So that could be a gel, a patch, a cream, a spray, etc.
Are you going to monitor that person differently because they have a family history of breast cancer or they're concerned? I mean, I know we've eliminated that's not a factor, but let's say I'm concerned about that, because I still have like that doubt of like, what if, So do you monitor that person differently?
Well, the person that has, let's say, the family history of breast cancer, grandma, 3 aunts, no genetic markers, but geez, there's a lot of breast cancer on that side. They're going to, usually when you fill out some of the breast cancer analysis scores, they're going to score greater than a 20% anyway. They're more likely to get a breast biopsy because of that history over someone without that history. If they're anxious about it, they're more likely to get a breast biopsy than someone not. So they're already going to sort of escalate up to an alternating mammo and MRI. So they're going to get some extra screening. And we can always think of a reason to order a screening or a diagnostic test if we want to. So yes, we try and appeal to the anxiety that's being caused, but the most important thing is that we educate you on where you should worry. And sometimes I say to women, you're spending an awful lot of time worrying about breast cancer. You don't have any additional risk. Your lifetime risk is 18%, which is not an increased risk. You should be focusing on your risk of heart attack and stroke. So let's get you doing your cardio or weightlifting or whatever. And I redirect them to their real risk of death.
And is there, what's the cutoff time of like when you can say like my mom, she doesn't need any more mammograms, but
how old?
She's going to be 70.
I would still
72.
Your peak risk for your breast cancer sort of peaks at 79 and then starts to come down. If a lady comes in and she's wearing sneakers and she doesn't need a walker, I'm going to have her go and get her mammo. 80, 85. The data shows that if you could stop mammos at 75 because they're not going to die from breast cancer, from a new cancer that developed after age 75, because it grows really slow. Everything does happen slowly after 75.
My mom got a mammogram 2 years ago, and how old is she? She's 84, so 82.
Okay.
Yeah.
And what's the earliest, like say that you have genetic testing, what's the earliest that a woman should go, a young lady should get tested?
So if I have a 20-year-old who tells me mom had breast cancer at 40, I'm going to order genetic testing on her so that she knows.
You're going to do genetic testing.
Testing. If her genes are negative, then she'll start testing 10 years before her mother's cancer. So if mom got it at 40, she's going to start at 30.
Okay.
Normally we start at 40.
If it's not the mother and it's just other relatives? And do you see a difference between if it's the relatives on the mother's side or versus the father's side?
Yes, we tend to sort of lean towards the maternal side.
Okay.
And we call the aunts and the grandmothers secondary felons. Okay. Sorry, Granny. I don't know where that came from, but second degree relatives, right? So our first degrees are mother, sister, daughter. The second degree family members would be aunts, grandmother, and so forth. So, but multiple second degrees does increase your risk. So general starting at 40, back when I was young, it was 35. That's been shown to just be way too young. So you had one at 35 and then you start at 40. Now it's every 1 to 2 years in your 40s, and then you start watching more closely at 50. You really start to see the uptick around age 63. The peak is by 79, but statistically, at age 85, 1 in 8 women at 85 will have or have had breast cancer. Wow. 1 in 8. So we're diagnosing it earlier. Women are living longer. It's not, the overall survival rate is 90-95% for all comers. So I don't want women to get stuck there and bypass important hormones that may make them feel better and improve their cardiovascular health and so forth.
I had genetic testing done about 2 years ago because my grandmother on the maternal side, she died at 54 from ovarian cancer.
Oh, yeah.
So that to me was always something in the back of my mind that I was very concerned with. And I was surprised that it was affordable. And I was able to get it done, and they came to my house. They did it very quickly, and I got the results in about 2 days or 3 days.
And you were fine.
And I was fine. I was negative. Yes.
So let's see, about 15 years ago, Myriad was the only one that owned the genetic testing. So a test was $3,500. So
I didn't pay that.
Yeah. And so they went to the courts. The other companies went to the courts and said, how can they own our genetic profile? And the courts ruled in favor. So then all the companies could make genetic testing. And now, even if you're out of pocket, it's $150, $150
I
max.
paid $150.
And if you have a first degree relative with a cancer like a melanoma, pancreatic, breast, whatever, usually that's enough to have the insurance company because it's so cheap. 23andMe, these tests that people do where they swab, a lot of times, a lot of them are testing for the same stuff. So if you have a normal one of those at-home tests and you've done the test properly, but it is now really affordable. So that should not be a reason.
What do you think about those 23andMe? Do you like them?
Yeah. So the only thing I learned about the 23andMe recently was because they used that data to find a murder suspect, which was the murderer that killed all the college girls. So one of the ways that they found him was they got his DNA from the Starbucks cup or whatever he was drinking. They were following around, taking his DNA. But then they ran through all the database on 23andMe and found his relatives. And through his relatives found out where he lived, who he was, and all this stuff. So I was just watching a recent court episode where the defense was saying, wait a minute, you don't have the right to get into everybody's 23andMe and just search the data pool for, matching. And they said, oh, yes, read that contract. So, when people, sign up and swab, you don't know where you're.
I've never done it because I've always felt like they have my DNA. Like what?
Yes, that's how I've always felt.
So I've never done it.
They've
Plus,
already got your
I really
DNA.
don't want to get a knock on a door from a relative saying, hey,
Yeah.
can you help me out?
I think I've never done those, but it is, it really does tell a story. But I think when you do those, you check a box that says, I don't want any family members reaching out to me, and I don't want to share that.
I know someone who had
I would check every box.
supposedly a cousin, never met him before, and started coming to his house and asking him for money. Yeah, it's kind of crazy.
Of course. There's always one of those.
That's very creepy.
Yeah. So I think that the technology is super cool. And if you want that information, I have a neighbor who she did one of those tests and she tested positive for BRCA. And I said, oh, well, you should be then getting this additional testing. And she said, no. And she sort of presented an interesting argument. She said, when they tell you that with BRCA, the risk is 60% higher for breast cancer, they're testing a pool of people that already have a known risk. They're only doing the BRCA testing on people who have demonstrated a family history that was risky. And then you do the test and you find it. Mm-hmm. She said, I think if we just did routine genetic testing across all people, that maybe the incidence of that 60% would be diluted out for all of us, like her and her mother, who had BRCA1, who didn't have breast cancer. So they said the pool of characters that you're looking at are already presenting with an increased risk.
Right.
So therefore, you're labeling this as a 40 to 60. And I thought, I mean, she's got a point there.
Yeah.
I don't know that I would just feel comfortable not doing anything.
Yeah.
I would say, maybe you don't have to do every single test, but maybe a little bit of advanced screening, maybe an MRI every other year, because a breast cancer doubles in size in a 2-year period.
Good to know.
My mom had breast cancer twice. So when I go to the gynecologist, that's the conversation we have.
So she had a recurrence in the same breast?
No, the next one.
So, and often when you see that recurrence, the younger the girl, the more likely the recurrence in 5 years. The older the person, it's more like 10 years. There's something about that 10-year mark that's sort of crazy.
Does HRT in some way protect when, like if they started early in peri, being HRT protect you from breast cancer?
No, I don't think any data shows that. Some interesting points there, though. If you took hormones and you did all right, but it wasn't as great as you thought, or the symptoms that were really bothering you have abated and you decided to stop, if you stop by 5 years on, no harm, no foul, nothing's changed. You have not increased your lifetime risk for breast cancer. The longer you expose your breast to estrogen, just over time, you've kept your breast more active by feeding it hormones, then you slightly increase that risk for breast cancer over time. But the idea is that you're working on maintaining your cardiovascular elasticity, and that maybe you're increasing the blood flow to your brain and improving the vascularity and improving your cardiovascular health. So people are sort of trying to balance all of this.
Right.
I have a question. For someone that had a hysterectomy done, how does that affect them in regards to perimenopause? So, like, for instance, for me, I had to have an emergency hysterectomy when I gave birth to my daughter.
C-hyst. Okay. Cesarean hysterectomy.
Yes. But I was never given any information after that about what's going to happen to my body.
Right.
So
it really depends on what goes on at the hysterectomy. So a cesarean hysterectomy, we leave the cervix and we leave the ovaries. The uterus is bleeding. You got to take it out or it's injured or whatever.
Right.
So when you just remove the uterus, which is the baby carriage, some of the long-term risks are pelvic support. You might have less pelvic support, but it really, other than the emotional impact of the trauma that you went through, A, you were bleeding to death, and B, you lost your uterus and your ability to have future children because of that. That's enough in itself to get through, but it really otherwise does not affect your ovaries. Your ovaries are still youthful, 30 years old, still trucking along doing their thing. So it shouldn't affect your hormonal health directly. Indirectly, yes, all the cortisol and the stress and the trauma, a little different story. So it shouldn't, there's some evidence that those ovaries may fail a little earlier because you've had some reduced blood supply to the area by the loss of the uterus. So you might experience menopause at 48 instead of 51, but it should otherwise be no different other than getting past the drama that took you there. When people say, I had a partial hysterectomy, so the lay term is partial or complete.
So what is that? Can you break that down?
Yeah. So removing the ovaries at the time of the hysterectomy is where things go downhill because you're getting put in immediate menopause.
Right.
So when I used to take the ovaries out for whatever reason, let's say endometriosis or something, I would always take patches into the recovery room and put a patch on my patient in the recovery room so that she didn't spend more than a half hour without any hormones.
wow.
And then if her intent was that she didn't want to take hormones later, then I could at least wean her off slowly while she was recovering from a hysterectomy so that she didn't have this abrupt stop. Also, women who are young, like 35, and lose their ovaries young for masses or cancer or whatever, they need testosterone right away too, not just estrogen. So the older ones can start with just estrogen and maybe fine when they lose the ovaries. So if you have a hysterectomy and your ovaries remain, that would be considered a partial in lay terms. To us, it's considered a hysterectomy without removing the ovaries. Then you shouldn't really be any different from a menopausal standpoint. You shouldn't wake up tomorrow and feel menopausal. Sometimes the ovaries sort of spasm a little bit for the couple days. Just like when people get chemo, sometimes the chemo shuts down the ovaries for a little while, but sometimes 4 years later, they wake back up again. So depending on the age.
Okay. And what about if someone ties their tubes?
Yeah, tying the tube, that is a good one. Tying the tube is really just blocking the hallway. You've just put a barrier up in the corridor between the uterus and the ovary, which is where the sperm likes to come through and hook up with the egg. So that happens in the distal tube and the end of the tube, and then it, walks down the hall and falls into the uterus and implants in the uterus. So tying the tube should do nothing. But girls will say, when I tied my tubes, my periods were the worst
I was just
ever.
thinking about that, like the egg coming down. I'm like, wait.
But the periods didn't get any worse. You went off the pill because you tied your tubes. And so your periods are miserable because you went off the pill. The tubal didn't do anything to your periods. The tubal was just your freedom from taking the birth control pills every day, but those were doing a good job at controlling your cycle. And now you don't feel good. So I always tell women when they're having their tubes tied or my husband's having a vasectomy or something, I say, caution, I've had you on the pill for the last 10 years because of horrible periods. You think you're going to go off the pill and be okay when he has his vas, because that's what he's thinking. No, your periods are still horrible. So before you make him get snipped, you better be sure you're not going to want to stay on the pill, because then he's going to get mad if he gets snipped and you stay on the birth control pills. So sometimes you have to think about some of those things. Why were you on the pill in the first place?
He's going to get mad about that pillow.
Well, thankfully, having a vasectomy does not ruin your erection. Many guys fear that it might, but no, they're not connected. So they're still safe.
I know you mentioned exercising and dieting. How do you feel about fasting for women?
Intermittent fasting.
Menopause?
I think whatever works for you, so if somebody hates to exercise, I'm not going to recommend exercise. I'm going to really recommend calorie counting and knowing your numbers and knowing how many calories you burn a day. And if you just like to take a walk, then take a walk. For women like me, I can hold a sign that says, we'll exercise for food. So I will do 20 more minutes of elliptical plus weights in order to have something that I shouldn't have. So whatever fits your lifestyle. So if you can intermittent fast and start eating at 11 and finish at 6, fabulous. That's perfect for you. Just sometimes my intermittent fasters, they're eating too many hours, number one. So the whole idea is to eat less hours. And two, too close to bedtime. You want to try and have an empty stomach 3 hours before bedtime. That's really probably the most important thing. So the thing that gets a lot of people in trouble is the snacking so when I was young, I would not eat the green vegetables. So my mother would make me sit there until I ate my vegetables. I was not eating the vegetables. So I'll sit there as long as you want to have a showdown, lady. I'm not eating my vegetables. And so she would, clean up the kitchen. The rest of the family would go in and watch TV and have a snack and dessert. I didn't get dessert because I didn't eat my vegetables. And then it was go to your room, right? Because now the kitchen was clean. She wanted to turn the light out. Go to your room. She actually helped me out there because I never learned to get a nice snack and some ice cream while watching TV with the family before bed. So I never developed that bad habit. That's a huge habit for a lot of my patients. That little bit of ice cream or
Especially when you're in perimenopause.
Perimenopause.
It's that little bag of the salty chips.
So the crunch is fresh.
I love crunch.
Crunching is frustration. Peanuts, pistachios. I mean, you could do a whole container from Costco.
Cashews.
Yeah.
I love all that. Yeah.
Of course, and the problem with the nuts is they're fat by definition. So the calories are enormous. Yeah. Where you look at the little pretzel bag and you go, okay, that's only 150 calories. Let me chomp on those. So crunching is frustration. So understanding what the crunch really means is part of where you're reflecting and going, okay, let me get self-centered here. What's frustrating me besides my whole day?
Well, I like to crunch on ice, but I noticed that when I'm a little stressed out, I crunch on ice.
Me too. Oh my gosh. That's
is that part of every day?
No, not every day. But I did notice that I have the little.
You can't go wrong with ice. But it made me think of a condition called pica, P-I-C-A, pica. Pica is people crave ice, chalk, various things.
Pregnant women do that, right? Some not. Not.
I've heard of the craving of chalk.
Cornstarch,
during pregnancy,
chalk, crayons.
Some kids do crayons. Children.
So it's related to anemia.
I can't believe that.
So the question is it the anemia driving the pica behavior, or is the pica behavior interfering with absorption of things and creating the anemia? I don't know the answer, but it's fascinating when people tell you, yes, my uncle's a teacher and he brings home a box of chalk, like chalkboard, classroom chalk, and I eat about 10 pieces of those a day. You think about how can that taste? That can't be good, but it's not rational.
Isn't that what is chalk made out of?
I mean, it's not good.
I'm thinking your stomach.
Nothing healthy. And that's called pica. So it's actually a condition. And it's more common than you think.
Yeah.
People just don't disclose.
I was anemic for a long time.
While you were pregnant?
No, just
as a person. Heavy periods.
Yeah. And I could never donate blood. But I was definitely an ice cruncher.
There you go.
Big time.
I think it's the anemia that drives the pica for some reason. I feel like when I try and go, which came first, the chicken or the egg, sometimes you really can't tell. But with a good historian, sometimes you can see that she was anemic and then developed this behavior.
Interesting.
But having a little ice before bed, you're not going to have any problem with that.
I just figure it's better than salt and vinegar chips.
Oh, without a doubt. Without a doubt.
I did want to ask you a question regarding perimenopause. What do you think is the first real true symptoms that you would consider, for lack of a better word, severe, where someone should say, oh, I need to go to a gynecologist or a specialist?
Good question.
In your opinion?
So severity is so personal about what one person thinks is more severe than the others. There's really nothing life-threatening in that list. However, the most bothersome symptoms are irregular periods, and the anxiety and palpitations are abound. Lots of complaints of that. And then the next would be the brain fog. So I would say, if anything, it's the brain fog, because the brain fog interferes with clear thinking. So decision-making could be poor, including your decision-making while driving. So if we thought of the highest risk, it might be that lack of sleep and the brain fog. But for the most part, none of the symptoms really lead to anything dangerous, but they surely lead to a poor quality of life.
Absolutely.
That's the magic word right there.
Right.
Quality of life.
Fog brain is just, I can't even explain that.
Women want to be able to do everything. And, as you know, sitting here, ladies, they're all very capable of doing it all. But it's very frustrating when something's interfering with your ability to control your world, like you're usually very good at.
Well, I get to the point where I try to ask myself, did I always feel like this? Did I ever not feel like I couldn't think clearly? Because you get so used to being like you said something in the beginning where 1 month is, you're a little bit more irritable. Next month, you're a little bit more moody, or the following month, and I feel like that. I'm always I notice that every other period, my mood swings are more intense. So 1 month, I'm really, really just angry and moody and vocal about things. And then the next month, I'm very
tearful.
Sometimes, yes, I definitely would cry, but it's more I just get numb and I mute and I get melancholic and I just don't, and then the next month comes and then now I'm back to but it changes, it fluctuates. And then sometimes I feel like I get one good week in the month because and I've noticed this myself, just years of just thinking to myself, well, my hormones are getting ready for my period. Then my period comes. Now my hormones are fixing themselves because I'm not on my period anymore. And then I'm going to be ovulating. And then it's I get one good week and I've noticed it because I'll be man, I feel good. But then I'm do I really only have 1 week? I mean, have I always just kind of felt like, because we've had our periods, since we've gotten them in our teenage years.
Yeah.
The definition of PMS, PMDD says that you must have at least one good week a month. And most girls will tell you that is really the week right after their period, as their period is ending, because your estrogen is on the upswing. And so we know when that's going to be, although I make women tell me, and it's, I usually say, how many good weeks do you have? So for the majority of women, their worst week is the 7 days before their period. Before the onset of the day of their period. For the rest of the group, it's usually the 2 weeks, so the progesterone phase. But I always say, are you tearful and lethargic or angry and aggressive? And they'll sit there and go, both.
It changes.
I start with angry, and then I feel embarrassed that I behave that way. And I used to remember myself during this period, and for me, it would be driving. So if you see, I drive a Corvette. So if you're in the left-hand lane and, sitting on the lane and not moving, I might be giving you hand signals back there, move to the right, going nuts. And then I'd go, oh my gosh, I hope I don't know who that is. So a pharmaceutical rep one day came in the office, Dr. Whelihan, were you on Okeechobee Boulevard on Saturday? And I was like, Yes, I was. She goes, you cut me off. And I was like, oh, like, did I do this? Were you on the left-hand lane? And I went, And she goes, that's exactly what you did. And I was like, oh, sorry. But you were going slow in the left-hand lane. And she said, I was going the speed limit. And I said, well, like I said, you were going slow. I said, let us speeders just go by. And we laughed and laughed. But I thought, how embarrassing, right? So you get in trouble that way, and we reflect on our behavior and say, oh, this is just not me.
Mm-hmm. I mean, I plan literally my vacations on the good week.
Good.
Because I just, it's not fair to the other people that, no, I'm very irritable. I get melancholy. I cry. And my husband has even said to me, that week that you're good, that's when I'm like, okay, let's just go do everything.
Game on.
Yeah. And I actually use a free app that's called Flow.
Oh, yeah.
FLO.
Yeah.
And it's pretty accurate, and it's free. And that's my little Bible.
So is it posted on the refrigerator so all the family gets warning?
Well, I mean, they kind of already know. But like, with all sincerity, like, even when I talk amongst people that I'm going to plan something, I'm like, no, I can go this week.
Yeah.
Because I just know my body. But I think I do recommend that for most women.
Get another pellet.
Yeah.
Just get that pellet. Yeah. It'll smooth you through all that.
Maybe I'll get 2 more weeks.
Right? I use a free app too, just to monitor my moods. Yeah, people usually use it for ovulating because they're trying to.
That's how I was using it.
I had one too. But I'm like, I was talking with a friend of mine. She's like, well, yeah, I just track it because I like to know, which I'm very regular still, but it's my moods that change. So that's what I like to follow. And then I'll look like if I have something for work or personal, or I'll be like, oh, it's going to be coming around that time. I might have a little bit of anxiety because I get anxiety right before. Yes. Not as strong. I just get antsy.
Yep.
I get antsy and I'm like, my period's probably coming.
And see, I think estrogen helps there. So yet there's really never been a study done to say, if you treat the PMS, PMDD, all the studies on PMS, PMDD revolve around the mood management because that's what's getting most people in trouble is their mood. So every randomized controlled trial showing efficacy was showing it with fluoxetine, sertraline, any of the mood drugs. So they work. But women don't always want to take that because it makes them feel like they're crazy. They know it's hormonal. So why can't I take estrogen? And when I thought of my time, exactly where my head was, like, this is the lowest period of my estrogen is this week before my period. What if I just took estrogen during this period and will I feel better? And the answer was I did. So was it a placebo effect? But within 3 hours of the onset of menses, I would be like, oh, this is like I'm normal again because your estrogen was going back up on the next cycle. So there's no harm in giving a little estrogen during that week before your period or the 2 weeks before your period. It's either going to work or it's not. And if it doesn't, then we move on to the things that the science has shown that works. But so many women get better that over and over again, I say, this is why I do this, because it solves a lot of problems and it solves it in the way that the woman would like it to be solved and not the way that's dictated.
I love that. Yeah. Wow. So you're saying, sorry, I just had one question about that. So you're saying that you don't have to take it daily. You can pick throughout the month when you take it. So you feel the effects pretty quickly.
Yep.
I didn't know that.
So the idea on PMS, PMDD is, you should be feeling the relief within 2 days. So if your PMS is 7 days before your period, maybe 9 days before your period, back in the day, I used patches. So I would slap on an estrogen patch, estradiol patch, and then I would just set it and forget it.
That's great to know.
And then you would move into your next cycle and I'd be going, oh, actually I'm feeling better. So I don't need that anymore. So when I prescribe it, I prescribe a whole month's worth, but a whole month might be 1 week every month for 4 months for somebody. Mm-hmm. Nice, very good and affordable.
I didn't have that luxury of tracking my period for 21 years.
You didn't have a uterus.
Yeah. So when I got pregnant, I lost track. So 21 years of me just not knowing what the hell is going on. Like why I feel the way I do.
Right.
Or not 21 years, but just for the most part.
What was your age when you had the C hysterectomy?
27.
Oh, super young. Yeah. It changes your whole perspective on things. While your girlfriends are going, oh, but you're so lucky because you don't have a period.
Well, I felt like that for a while. I was like, yes, damn, I don't have to deal with that. But then as you get older, you start to think, okay, wait, now I'm hearing all these things and I'm like, wait, what should I have been doing all that time to help me?
Yeah.
You know, so.
Do you know when your mom went into menopause?
No.
They don't remember.
I know.
Yeah.
No.
Do you have any older
My
sisters?
mom just says
They don't
no.
talk about
I'm the
it.
only girl.
How old are you?
48.
Oh, well, you're close. I would just be treating you. You're the easiest one to treat, right? Because the potential side effect of treating somebody with hormones before their periods have subsided is irregular bleeding. I'm really surprised at how often that doesn't occur, because we use both hormones and we know what the effects are. But you're the easiest one because we're not going to worry about irregular bleeding. You have no uterus.
Yeah, I mean, I got dismissed by a couple doctors.
Oh, yeah.
Yeah.
Oh.
And the last one was like, no, you'll get cancer. So
Yeah.
I was like, okay.
Now you've heard the word.
Yeah.
Wow.
Wow.
The science.
Thank you so much for
Science.
everything you've taught us. I feel like the knowledge is I feel empowered with the knowledge.
I'm so glad.
Awesome.
Me too.
you so
I just want to
much.
keep talking to you.
I'm sure all your patients feel that way.
We can do this again.
No, that I love that idea because we do like a part 2.
Well, I liked our conversation
I'm like,
before the podcast.
Oh, me too.
That was a
Yes,
little.
I was going to say that.
I know it's not appropriate now, but we were talking about some
sexy
very
side.
affordable vibrators.
Intamina Kiri, Kiri. Absolutely. And right now it's on Walmart.com for $6.83.
It's very small and discreet.
amazing.
Yeah.
Any other questions? I feel like, wow, we really dove in.
Yeah, and we dove in deep. I think it was great.
Yes.
Thank you
Got
so
full
much.
circle. We covered a lot
Yes.
of topics.
Would you be willing to come back in the future?
Sure.
Oh my God, yes. We'll make it a sex special.
Yeah.
That's right. Love
Whatever.
that.
You hear that? Part 2, guys. Whoever's listening.
Yes.
Thank you so much.
Thank you so much for coming. What a powerful and informative conversation. So, Dr. Whelihan, any final thoughts? Any advice? Anything you want to say?
I hope what your listeners hear tonight is be your best advocate. If you're getting the answer that doesn't seem right from the person you're asking, ask someone else. And with these days, you have the Mary Claire Havers online doing all of her blogging, who are actually out there advocating for science-based, evidence-based data. I love that. You can certainly find lots of solutions that are more interested in your wallet than the science. So you just have to be very careful. If you're laying out, a couple grand just to feel better, maybe investigate something else, but ask. And if your doctor just doesn't feel comfortable with that topic, ask if they can refer you to someone who does, because they know.
Where can listeners find you or connect with you?
So the office is located in Lake Worth, but I've posted some fun things on LinkedIn, so they can search my name on
find
LinkedIn.
you.
There's some articles there that really dig deep. They're fun. They're always humor-based. So my approach is always with laughter. So this was a perfect forum for me because it is sort of funny, not funny sometimes,
Right.
but it really takes it to a different level when we can laugh about the changes and learn how to fix it. So all of my articles always have a little sarcasm or fun or laughter or naughtiness in it. So there's some fun pieces there.
Oh, good. I'm going to find you. Yeah. Well, to our listeners, if you found this episode helpful, be sure to share it with a friend who might need to hear this conversation, just like today. So if you enjoyed today's conversation, don't forget to subscribe to Red Lips Real Talk and leave us a review. Your feedback helps us continue bringing important conversations like this to the forefront. Thank you for tuning in. Take care and keep the conversation going.
Hasta la próxima.
Thank you.
Thank you for listening. Make sure to subscribe to our show so you don't miss an episode.
We will be dropping an episode every 2 weeks.
Oh, yeah. No, seriously. Subscribe now.
So just chill till the next episode. Follow us on Insta and TikTok.